Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Oxnard Health System and Humana to bring Oxnard's Hello Health weekly education and information series to you. Our topic this week, hearing loss and how it can be restored. Our guest is Neurotologist Adam Master. First, some background. Dr. Master is a Louisiana native. He received his medical degree from the LSU School of Medicine in Shreveport. That's where he's from. He also completed his residency there. His fellowship work was done at the world-renowned House Ear Clinic in Los Angeles. It is our pleasure to welcome Dr. Adam Master to Hello Health. Good to have you with us on the program.
Thank you, Tom. Wonderful to be here.
And welcome to the city. You haven't been here long officially, but you did do some time here, right?
That's correct.
Studying at Tulane.
I did my master's at Tulane in neuroscience. I guess it was in about 2007 now.
Great. Well, good to have you and your family on the Oxnard team and here in our city. So not to be confused with a neurologist, and actually it's a subset of a different specialty. What is a neurotologist?
So a neurotologist is a little known field within otolaryngology, and that's ear, nose, and throat. You may be more familiar with that term. But neurotologists do an additional 2 years of training looking only at the middle and inner ear. So we specialize in the medical and surgical disorders of the ear. This includes hearing problems as well as balance issues and chronic ear disease.
Do you remember what it was or who it was that first got you interested in this area or specialty of medicine? What attracted you to this?
Sure. So my mother was a neurologist, and so I was always fascinated by the brain, and I had an older brother that had gone into cardiology, like my father, who's a cardiologist, so I knew I wanted to kind of go a different route. And then I kind of realized early on that I liked doing surgery and thought about doing neurosurgery, which is another good field, but I tend to like more the outpatient setting and dealing with patients that are less critical and I can make a big difference for them. So I got attracted to ENT, and then within ENT I kind of found its connection to neuro, which is in the ear portion of it, and fell in love with the anatomy. I love that I get to treat older patients as well as children, and for the most part they're otherwise healthy except for their ear issues, so if I can make a big difference for them there, they usually appreciate a lot.
It's a great point. In some of those other specialties you're saving lives, but you're really improving lives every day for people.
Correct.
Yeah. So why should people be concerned about hearing loss?
Hearing loss, years ago really wasn't taken seriously as a health problem. Actually, when in the 1960s, when Medicare decided that they didn't need to cover hearing aids for individuals, because people didn't take hearing loss seriously. Nowadays, we're realizing that hearing loss is an extremely serious problem. Causes depression, social isolation, affects people's ability to communicate with their partners, with their families. We often find individuals that have withdrawn from their social surroundings due to their hearing loss. And what we're learning now, it's a risk factor for other problems as well, too.
How common is hearing loss in the adult population?
Hearing loss is extremely common. And the U.S. population as a whole covers about 16% of the population. But looking at our senior citizens, it's about 50% of individuals over 70, 80% of individuals over 80. So this is something that is 1 in 3 adults experiences.
Our parents, or at least my parents, warned me about wearing the headphones and listening to Bruce Springsteen too loudly. Concerts, we hear about the decibel level at concerts. How much of that factors into all of this?
Noise-induced hearing loss is what you're bringing up, and that definitely plays a role. But certain individuals are more sensitive to others. But definitely being exposed to noise is definitely a risk factor for developing hearing loss early on. Although you see some individuals who are exposed to one episode of using a jackhammer and have permanent hearing loss that time, while other individuals might be in a rock band all their life and not have hearing loss. So there's some genetic factors that play a part as well.
Yeah, so what are the factors for hearing loss? So we look at all of them, the causes.
Sure. So noise is a common problem. and then family history of hearing loss, exposure to certain toxins, often medications may play a role. Certain chemotherapy treatments may be a risk factor for hearing loss. And then things like ear infections and infectious problems that may lead to hearing loss too as well.
What about Q-tip use and Q-tip abuse?
So Q-tips are probably something I deal with a Q-tip related problem probably every day. Most commonly, common misconception that Q-tips are used to clean the ears. And the most common thing we see is impaction of earwax, or what we call cerumen. But there are more problems they can cause too as well. Often outer ear infections because they can cause micro tears in the ear canal. We do need some earwax, so removing a lot of earwax can cause problems with ear itching, ear dryness. And then it can cause trauma. Often, people don't think they're getting into their ear canal very deep, but the ear canal is only about 2 centimeters, so it just takes a little bit to be touching the eardrum. I've seen numerous ear perforations. I've seen one individual rupture their inner ear with a Q-tip, causing complete deafness in the ear. So really should avoid Q-tips if you can.
Take us back to biology class. How does the ear work? What are the different components that we're going to need to understand better for this program?
Sure. So the ear can be broken up into 3 simple areas. The outer ear is what we see every day. This is what funnels sound into our ear canal. And so the outer ear encompasses the auricle that you see out here, and then that also includes the ear canal. And then the middle ear that we hear commonly, this is where the mechanical aspect of the ear is, and this includes the eardrum and the middle ear space, which is filled with air. Within that space, we have the 3 smallest bones in the body, the malleus, the incus, and the stapes. Your third, so sound is conducted by the eardrum, vibrating like a drum, and then transmitted through those bones. And then it goes to the hydraulic portion of the ear, which is the inner ear, and also has the sensory portion. So the fluid in the inner ear moves with the vibration, then this is converted by specialized nerve cells that we call hair cells that convert it into electrical information and send it along a nerve which travels to the brainstem, and then the brain in the cortical centers puts it all together.
What's happening to the ear when we're looking at age-related hearing loss?
So age-related hearing loss, the medical term for this is called presbycusis. And this is essentially an aging process, but not everyone experiences the same rate of hearing loss or the same degree of hearing loss. And we're not sure exactly. It's probably due to environmental factors, noise exposure. But what's happening essentially is these hair cells that I mentioned earlier are actually dying off. And we start losing a large population of the hair cells before we even achieve significant hearing loss.
If you asked any of my colleagues or my wife, they would probably tell you I need a hearing aid. I don't know if they're joking or not. Sometimes I'm part of the joke and will say something silly when I can't fully understand them. But how does someone officially know they need a hearing aid?
Right. So to know that you need a hearing aid, first we have to determine whether or not you have a hearing loss. Signs of having hearing loss would be, individuals having to repeat themselves a lot to you, or you having to ask individuals to repeat themselves a lot, noticing that you're missing a lot in conversations. Those are some certain signs, and from there we can go and do formal hearing testing. And hearing loss ranges from mild to profound. In any degree of hearing loss, technically somebody could benefit from using a hearing aid, although most individuals with mild hearing loss may not necessarily seek out a hearing aid.
Is most hearing loss, especially age-related hearing loss, very gradual over time, where someone might not even, people around you may notice, or may not if those people are around you every day?
Right. Hearing loss, part of the problem is it has a very insidious onset, and it starts off very mild, and so an individual might not recognize they have a problem because of the such slow onset of disease till years and years later, when they may already be experiencing a lot of the negative side effects of having hearing loss.
Let's talk about the role of hearing loss and dementia.
So this is a very interesting area of research. In a study looking at 20,000 participants with age-related hearing loss, they found that it was significantly associated with decline in all areas of cognitive domains, as well as increased incidence of dementia. This doesn't include Alzheimer's dementia. And that actually the degree of hearing loss, whether it be mild, moderate, or severe hearing loss, actually increased the risk of progression to dementia. And so a lot of this data came out in the last 5 to 10 years and has been a big topic because for dementia, which is a big problem that costs about close to $1 trillion a year for the healthcare system, there aren't many modifiable risk factors, and hearing loss may be one of those.
Let's go back one question about determining whether or not someone needs a hearing loss. Can you give me any simple tests that a spouse might do at home for another spouse, or someone just might ask themselves? Any tests at home other than, like again, I joke that I can't always hear my colleagues. But,
sure.
I know, for example,
rubbing your fingers. Right. If you're unable to hear, rubbing your fingers, you probably do have a significant hearing loss. That would be about a 30 decibel, sound. So if you can't hear that gently, then there is probably significant hearing loss. In the office, we use tuning forks to kind of help determine what degree of hearing loss people may have before going on to formal audiometric testing. Other things would be, talking while covering your mouth. A lot of people that have hearing loss tend to read lips. So if individuals
not even knowing they're doing so.
Not even knowing they're doing so. When you take away visual aids, then people have a lot more trouble. That's why a lot of individuals with hearing loss don't like talking on the phone.
And when you lose hearing, different sounds, spectrum of sound, do some people lose the highs and not the lows, or vice versa?
That's exactly correct. So especially in presbycusis or age-related hearing loss, we tend to lose the high frequencies first. And even with having normal hearing and having high frequency loss, so quote unquote normal hearing based on the way we grade hearing, people might notice they might have trouble with consonant sounds, might have difficulty in loud environments. And most hearing aids are designed to treat high frequency loss for the most part.
Our guest this week is neurotologist Adam Master, and we're talking about hearing loss and how it can be restored. Any other treatment options for age-related hearing loss other than hearing aids?
So hearing aids are definitely the primary treatment used for treating hearing loss, but in certain individuals there is another option called a cochlear implant. Cochlear implants are indicated for those with moderate to severe hearing loss that no longer benefit from hearing aids.
And with that, the doctor is going to take us into a cochlear implant, show us how that works, and show us how the surgery works. So let's take a look.
So I just wanted to go over a little bit what it's like with the cochlear implant surgery. This is the external ear here, and we make an incision behind the ear, approximately 4 centimeters in length. This model here shows the implanted device. It sits under the bone here, above the bone here and under the muscle. So this is what the device actually looks like that's implanted. So you can see it here in profile view. And this is what our actual electrode, this is the real size of it. And it's curled up now and it assumes that shape within the cochlea to fit into the spiral shape of the cochlea. So this is the external portion of the device and couples with the internal portion through the skin. So you can see it attaches with the magnet here. It would be something like that. Patient comes in to outpatient surgery and has a procedure, is able to go home that day. Most patients report minimal pain with the surgery. I've had a number of patients report that they didn't even need to use any pain medicine after the surgery. Without having been somebody that's personally heard with a cochlear implant, it's hard to know, but most patients describe it as sounding robotic or mechanical sounding at first. And then over time, it becomes a very natural hearing to where they may not notice a difference. And that's partly because the hearing goes from not just the function of the inner ear, the hearing nerve, but also there's a lot of processing that goes on in the brain. And so over time, it's able to adapt the information that we're sending to it and make it into what it's more used to. Definitely they hear different than with a hearing aid. It's a totally different way of hearing, but over time, most patients feel that it becomes a lot more natural and something they're used to.
Well done. So with hearing aids, batteries have to be replaced. With cochlear implants, is that a permanent fix?
So cochlear implant is very different, worlds apart from a hearing aid. It's essentially a bypass of the inner ear, so we're directly stimulating the hearing nerve. But the external portion of the device does require batteries, and they do have to be changed quite often, much like a hearing aid. But we're not having to do surgery to change the internal device. The internal device stays in pretty much for the life of the individual. And most of the technology that's updated is going to be to the external device. That's where the processor is. That's where the main technology of the device is. So
we got to see some of the pieces, but you
Sure.
brought them along with you as well.
Yeah. So
give
Tom,
us some scale.
Tom, I have here. This is the actual device that's implanted. So this is the magnet that communicates with the external device, and then this is what we actually put into the cochlea. So I'll let you take a look here.
I'll hold that here. Alrighty.
And then this is what the individual wears, the patient. So it's about the size of a large hearing aid, but still can be relatively concealed. And this portion sits on the ear, has a microphone here, and this is where the processor would be. And then it's sent, the information's turned into electrical signals and sent to the transmitter, which communicates with the internal device. But we also have some newer devices where this kind of replaces the external device, and they just have this little portion here. So it's quite concealable for an individual with, long hair.
I'll never be confused with a fashionista, but does this come in different colors?
It does come in different colors. We have all different colors, and people love customizing them, so that's definitely an option.
When we hear cochlear implant, most of us think of people who've never been able to hear, and we've seen the videos where people have the surgery and hear for the first time, and it's miraculous. But so we've certainly moved on from just using it for the deaf.
Correct. So, a large portion of our implants are done for children born with deafness, but in adults, we mainly implant individuals that have had hearing before and that have lost their hearing either due to presbycusis or to other causes of hearing loss. And originally, when these devices came out in the 1970s and started being used in the 80s and 90s, we were only doing those that were profoundly deaf. But we're finding for individuals who have difficulty with word understanding and may not do as well with even moderate hearing loss, may not do as well with hearing aids, they may benefit from a cochlear implant.
How expensive is a cochlear implant, and is insurance willing to help out?
Sure. So cochlear implants are very expensive technology. The device itself costs about $30,000 roughly. But they are covered by all major insurances, including Medicare, if patients meet the criteria for implantation. That's because it's such a benefit to them in their life.
Now, this is a surgery, but it's not considered a major brain surgery, right? And we brought along something to show our viewers, but we do want to warn you that it is surgery, so if you get squeamish about these, it is a medical program,
Correct.
So we don't mind showing
Correct.
it, but we do want to warn our viewers that if you're a little squeamish about these things, maybe you'd turn away for just a minute. We'll let you know when to come back. But walk us through what we're seeing here, Doctor, and the level of surgery required.
Correct. So it's an outpatient procedure. It usually takes about 2 to 3 hours. Patients go home that day, often need very little pain medication. A lot of patients that I see with severe hearing loss have been scared to look into a cochlear implant because they were scared of surgery, but we're doing these types of surgery in all ages. We don't really have an age limit. It's kind of individual dependent. The image we're seeing here, it's actually bone surgery, so we're not going into the brain, but we're going through the skull base, and this gives us access to insert the electrode into the hearing organ, the cochlea. So this is an image showing the electrode being inserted into the cochlea.
Best you can, because I don't think you've had a cochlear implant, but what does it sound like to a patient, to a cochlear implant patient?
Most patients describe the sound initially as very mechanical sounding, robotic sounding. But it's fascinating. The brain is able to kind of take that information, and over time, patients say the quality and the clarity of the sound improves tremendously, and they continue to make improvements even up to a year after having received the device.
What is the expected outcome of an implant? What realistic expectation?
So, everybody can have, there's all ranging outcomes with implants, but the vast majority have significant improvement in their ability to understand speech. Most are able to talk on the telephone with their device. They're able to understand without having to read lips. And studies have shown significant improvements in both quality of life and also depression and improving mental and cognitive function.
Question of the program. What you talked about, one of the things that attracted you to this area is being able to help people in their day-to-day living. What is it like now, not necessarily for someone with age-related hearing loss who can now hear like they used to be, or can hear better, or whatever the case is. But take me to a patient where you perform the surgery who has never been able to hear, and they are hearing for the first time. Can you tell me what that must be like for you, for the family in the room, for the patient to actually be there and see that magic moment?
Right. So most of the time that's going to be in our pediatric patients because we don't necessarily implant deaf adults. But in our pediatric patients, it's life-changing that we're taking a patient that may have been, relegated to never, be able to do, certain things in their life due to their disability. And, their parents most of the time are hearing parents, so being able to live in their world and interact with them is wonderful for them.
Now, I have seen it done with adults, but you mentioned we typically don't. Is there a reason for that?
So there is a sensitive period that occurs usually before age 2 where we're able to learn language and speech best. And we do implant children older than age 2, but their expected outcomes will not be as good as infants and toddlers. So they may or may not be able to develop speech and language after that. But some individuals, even patients that have been deaf all their life, if they have expectations for at least being able to hear environmental sounds, if their expectations are reasonable, they may benefit from an implant. But an individual who is deaf and who is, an adult, they will not develop speech or language from using an implant.
How has the technology for cochlear implants evolved?
So mainly the changes in the device have been to the processing, which has gone from being single channel electrodes to multi-channel to having very complicated processing programs that are within each device that help send coded information to the hearing nerves. We have very good audiologists who are able to adjust these programs for the patients, and results that we're getting today are much, much better than we had in the 80s and 90s.
Are there different options for patients today?
So there are, we leave it up to the patient to decide which company to use. So there are 3 main companies in this country. There are others also, but in this country there are 3 main companies. They all make cochlear implants that work equally well, but we like to let our patients choose the individual bells and whistles that come along with the devices, and they tend to like that.
And back to hearing aids for just a moment.
Sure.
I've seen hearing aids advertised for $39.99 in magazines, and I've heard stories of hearing aids that can cost $5,000 or more. I'm imagining that the $39.99 one is nowhere near the $5,000 one, but what advice do you, and I know this audiologists are the expert in this area.
Correct.
But what advice when your patients, what advice would you have for your patients and the people watching here for choosing, and I'm sure there's a pretty good range too in there. What advice do you have for people looking at hearing aids?
Well, it depends on the degree of their hearing loss problem. Most of the time when we see these advertisements that seem to be reasonably low, these aren't true hearing aids. And what I mean by a hearing aid is a device that's programmable for their hearing loss. So when somebody's tested for their hearing loss, we have their audiogram, which shows what frequencies their loss may be, and that may vary between the low tones and the high tones. And if you amplify all those tones, people are going to hear everything, and they're going to be overwhelmed by the sound. They're going to get feedback. So most of the devices you see advertised are simply amplifiers where they amplify all sound. But a hearing aid can be programmed for someone's hearing loss, can be adjusted as needed, and that is best done by an audiologist who is skilled at doing that. And a lot of people get their hearing aid the first time, even if it's a real hearing aid, and they go home and they want it to work well, and it doesn't, and then they put it in their drawer and they forget about it. But really what they need to do is go back to their audiologist, have it programmed, and from there they can make a lot of difference. It's not like putting on a set of eyeglasses. Hearing's a bit more complicated than that, so it takes some tinkering and some getting used to. But vast majority of people that do use hearing aids feel they receive benefit from them.
And just 30 seconds left. What do you hope viewers walk away with from this program?
Well, I hope they learn to not ignore if they're having a hearing problem, and to seek out medical help and treatment for that, because it may really enhance their life and has also decreased the risk of some serious problems such as dementia.
Thank you very much.
Thank you very much,
Good
Tom.
to have you, Dr. Master. Thank the doctor for the education and information he has provided, and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including this week's guest, or to register for any of our Ochsner's Hello Health seminars, they take place almost every week across the city. You can call Ochsner at the number you see on your screen, or send us an email. There's our address, hellohealth@ochsner.org. As a reminder, you can re-watch this week's presentation and many of our other Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search box. Our thanks again to this week's guest, Dr. Adam Master. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. I'm Tom Bagwell, and we'll see you next time.